Hey, welcome to the Healthful Woman Podcast, the fastest growing podcast in women's health. Today's Monday, January 26th, 2026. 2626. My guest today is Dr. Shari Gelber, and we are going to discuss CMV, cytomegalovirus in pregnancy. I've gotten a ton of mailbag questions on CMV in pregnancy, so I figured probably best to just devote an entire podcast to this important topic. I'm glad Shari was able to join me as she has a lot of knowledge about CMV and many other things for that matter. As a reminder, please do keep sending in the mailbag questions. If you would like to do so, you can email us directly at hw@healthfulwoman.com or go to our website and click on the link that says send us your questions. Please remember the questions you send in are for mailbag podcasts. They're not for your personal medical advice that you need answered quickly, because I don't answer them quickly. If you have a question about your own health, please ask your doctor. All right. Thanks for listening. See y'all next week. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. Dr. Gelber, welcome back to the podcast. I'm really happy that you agreed to do this. I asked listeners to send in questions for mailbag podcasts, and we get a lot of CMV questions, and it's really hard to answer them briefly. And someone sent a really good suggestion saying, dude, just do a full episode on CMV and pregnancy. I was like, great idea. So I'm really happy we're doing this. I'm happy that you're coming on because I really do appreciate your wisdom on this topic. And it is a very important topic. So thank you for taking the time for me and for our listeners.
Not a problem. Happy to be here.
Excellent. So I guess let's start from the beginning. How would you explain to somebody who maybe doesn't know what we're talking about, like, what is CMV and why should people care?
So CMV stands for cytomegalovirus, which is really not helpful to anyone, the name, but it is in a family of viruses called herpes viruses. And, the thing everyone knows, that's a herpes virus is herpes, like HSV1, the thing that gives us cold sores, HSV2, which typically we talk about giving genital lesions, but like chickenpox is a herpes virus. There are a lot of viruses in that category. And one of the things about herpes viruses is that they can give you an acute infection where you get sick. So like people get chickenpox, they get sick. And then they can get shingles later in life, like their latent virus can reactivate and that can make them miserable, but like usually not sick the way the original infection made you sick. And people typically, if they get like cold sores, like the first time they get them, they get pretty sick. And then they get things later and they're probably not going to be systemically ill. But with all of these things, you can have virus in your blood when you get infected, when the virus reactivates later. CMV is something that typically we get from other people's bodily fluids, urine, saliva, blood, in theory, although that's not a typical way it would get transmitted. And usually in adults, it doesn't make you sick. It can make some people sick, but typically it doesn't make people sick. But it can get into your cells and reactivate later in life. But the reason we care about it in pregnancy is because CMV is the most common non-genetic cause of hearing loss. So for children who have hearing issues, if there's not some genetic reason, it's usually because of CMV. And CMV is very, very common. Between 0.5% and 1% of children are born with congenital CMV.
Just to clarify, between 0.5% and 1%.
Yes.
Right. Okay. Between zero,
so like
yeah,
99 to 99.5% children are not born with congenital CMV. So it's uncommon. There are like 40,000 children a year in the US with like symptomatic congenital CMV. And so people get it because they get exposed to it in pregnancy, but also it's complicated because newborns or fetuses can also get it because their mom had it in the past and it reactivates. And so there's not like a good test to do for people before they get pregnant to say, well, you can't get CMV in this pregnancy, that your baby is 100% protected. And that is stressful for people because it is in the world around us. And I think recently it's been on people's radar more for two reasons. For our patients, New York State made CMV screening part of the newborn screen for, I think, between 2023 and 2024. I think there was like a little over a year where when they did the heel stick on newborns, they were sending that for CMV unless people opted out. And it was sort of hard to opt out. So people generally didn't. So a lot of people heard about it because they knew someone who was contacted they were contacted because their baby was CMV positive. And then also we're still dealing with the repercussions of all of the lockdowns during COVID. Like, I think there's been a big uptick in a lot of infectious diseases that we didn't get when people weren't touching other people. And now they're sort of coming, like, you would have had like a steady however many people a year were getting these diseases, and instead nobody got them. And then suddenly there were all of these susceptible people getting sick all at once. That's been a bigger thing with parvovirus than CMV, but I think it's probably true of CMV too.
Yeah, I mean, I think that there's a couple things, and that was a really good overview of CMV. There's a couple things to unpack that I think are really key points. And that the first is that, for people listening, most viruses that people get, and where they would get, whatever it is, a cold, a flu, ranging from mild to severe, whatever it is, if they get it when they're pregnant, most of those viruses will not infect the baby, will not hurt the baby, will not cause any problems in the baby, no birth defects, no issues, this or this. Like if someone gets the flu, like our concern with the flu is the mother, that the mother's going to be sick. It's not that the baby's going to be born with like congenital flu and have birth defects. And that's true with most viruses around. But there are a few that can infect and cause harm to the baby, and CMV is one of them. So that's like sort of problem number one about CMV related to pregnancy. And problem number two is what you're saying is that it is some of the viruses where this can happen, like for example, like you were saying earlier, parvovirus, it's the kind of virus where you get it once and you don't get it again, right? So if you get parvovirus, you're not getting it again. And so if we check and someone has antibodies to parvovirus, they're immune to it, they're not going to get it again. But CMV is not like that, meaning you can have had it in the past and it can reactivate in your body. And so finding the antibodies doesn't give you that sort of guarantee, so to speak, that you're not going to get it in pregnancy. And I think that's really sort of what makes it unique compared to many of the other viruses that we talk about in general.
Yeah, that's exactly right.
So taking both of those, right? So let's take the first part, the part where it can infect the fetus. So what happens? Like what could happen during a pregnancy if the mother got CMV during pregnancy is sort of question 1A. And question 1B is if it got reactivated, right? Because I will spoil alert, it's different, right? It's worse if you get it the first time than if you get it reactivated. But sort of what are the things we're worried about other than hearing loss in a newborn?
So the reality is that the vast majority of women who get CMV in pregnancy are not going to have children with congenital CMV. Like the mom will get it, she'll clear it, the baby won't be infected, everyone will be fine. But sometimes, like when there is primary CMV, so you're getting CMV for the first time, either preconception or periconception, like around the time of conception, or, at some point in pregnancy, about 1 to 4% of women get a primary infection in pregnancy. And then about a little less than half of the fetuses will be infected. 10 to 15% will be symptomatic at birth. And then 25% of them will have something like, be it hearing loss or neurodevelopmental issues by age 2. So most people will be fine. The most common thing is hearing loss, but then sometimes babies can be born and they can be very, very sick. They can have what are called petechiae, which come from having low platelets, or the head can be very, very small. And I hate to say that because lots of fetuses on ultrasound have small heads and, we think about it, but that is probably one of the things that worries parents the most is they'll see the number on an ultrasound and they'll be worried even though we are not worried. And we're not missing a lot of symptomatic CMV by not having a bigger cutoff for head circumference. But the head can be really small and that can be associated with developmental delay. The spleen and the liver can be really big and not functioning appropriately. And especially babies that are born prematurely with CMV can be very, very sick. It is rare for babies to be very, very sick, but it happens.
Is there a way for someone to know? Let's say we did know that they got CMV during pregnancy. I know that's a whole other conversation that we'll have. But let's say you knew you got CMV in pregnancy. Is there a way to know what are the chances my baby's going to be symptomatic or not, or sick or not while you're pregnant?
Well, if you have CMV in pregnancy, we recommend that you have an amniocentesis, and then we can look and see, did the baby get an infection? And if your amniocentesis does not have CMV in it, it would be very, very surprising if the baby was affected. And then it's more complicated if there is CMV in the amniotic fluid, because again, most people will be okay, but sometimes babies will be very sick. And I think it depends on what we're looking for. So if you tested someone's blood every month and there are no signs of CMV, so you have a positive blood test at some point, but there are no ultrasound findings, that's going to be a baby that's more likely to be okay. Whereas sometimes we do an amniocentesis because we see signs of CMV on ultrasound. Either we see something in the brain, it can cause calcifications in the brain, or we see something in the liver or the bowel, or the baby is very, very small, or the head is very, very small. And those babies that are showing signs on ultrasound are much more likely to be sick when they're born.
Yeah, and there's no way on a podcast we could tell anyone who's listening, who's worried about this for their own pregnancy, here's your chance, right? It just doesn't work like that. It has to be individualized. But so on our end, I guess, the amniotic fluid that we test for an amniocentesis is baby pee. And just like in a newborn or an adult, you can do a urine test and check if there's CMV in your body. What we do is we do an amnio. It's basically a urine test on the fetus. And if there's no CMV in the amniotic fluid, basically the conclusion, it's not 100%, but as you said, it's very close to 100% that the baby does not have CMV. And so you're probably in the clear, which is great. Now, if it does come out that there's CMV, it's hard to quantify, but logic dictates if we're seeing abnormalities on ultrasound, that's more likely to be a baby who's sick than if we see nothing on ultrasound. And none of these are guarantees in either direction. It just sort of moves the needle a little bit. Now, what about if we were confident that the CMV that the mother has is not a primary infection, but it's a reactivation of an old CMV, right? So we know definitively that she had CMV 5 years ago, and now she's pregnant again, and we suspect that she got reactivation of CMV from a blood test or whatever it is. Is that a situation which is, and I gave the spoiler before, that is less concerning? And if so, to what degree?
It's much less concerning. So for people who reactivate their CMV in pregnancy, between 0.5% and 2% of newborns are going to develop a fetal infection. And that was compared to primary CMV, where 40% of fetuses are going to develop a primary infection. So it's like the difference between practically half and 1%.
Yeah, so much different.
And then of that, 1% that develops an infection, less than 1% are going to be symptomatic at birth, compared to in the other situation where with the 40% of fetuses that were infected, 10% were going to be symptomatic at birth. So you're less likely to get the infection. And if you get the infection, you're less likely to be symptomatic. And then you're less likely to have problems later. So it's not a guarantee. It's reassuring to have had CMV in the past.
So knowing all of this, right, that CMV is out there and it is very prevalent. I mean, if you just sort of randomly blood test people, about 50% of people will show evidence that they had CMV at some time in their life. It's very, very common to get this at some point. So knowing that, right, what should we be doing about it, right? Because there's a lot of debate and different people do it differently. Like, should we just wait to see if someone gets sick? And if they get sick, test for CMV? Should we be testing blood for antibodies routinely before pregnancy, during pregnancy, serially in pregnancy? And if it's not determined what the best thing is, what are sort of the reasons why you would do one or the other, or why there's disagreement about this?
So they have looked at this. There have been a few studies looking at checking people's blood repeatedly. And there's generally a feeling that we should not be doing that because there tends to be more harm than benefit. Like in studies where they looked for people seroconverting, a very high percentage of patients ended up terminating their pregnancies, sometimes before doing an amnio. So they didn't even know if their baby was infected. They're like, I'm not taking any chances. And the frequency of that was so high that it was viewed as an intervention that was causing more harm than benefit.
Right. And just to clarify, seroconverting means you find someone, they first have no antibodies, and then they have antibodies. So the assumption is between point A and point B, they must have gotten CMV.
Yes.
Okay.
The argument, so I'm going to take a step back. What I write in my consults, when I see a patient for preconception counseling, is that I don't recommend routine CMV testing in pregnancy. But I qualify it that if you're going to do this, because a lot of doctors do this, you should do the testing before pregnancy so that if the patient is already IgG positive, that's helpful. And if they're negative and then later they're positive, you can presume it's a primary infection and counsel the patient that way. But just going into it in the first trimester, sending tests for antibodies is frequently very, very confusing. And it can be very, very hard to ascertain how long ago the patient acquired CMV and if the pregnancy is at high risk or low risk.
Yeah. And in practice, this happens all the time where people, they get a blood test in the first trimester. There are some antibodies to CMV, and then either there's an assumption, I must have gotten CMV in pregnancy, or a question, did I get CMV in pregnancy? And it's hard to sort it out. And that's because the antibodies is not that straightforward. I mean, for those listening who care, there's two kinds of antibodies we look at. There's the IgG and the IgM. And the thought is that when you get, and this is true for many viruses, but when you get CMV, the first thing that comes out positive is IgM. They sort of happen rapidly. And then eventually your body develops IgG. And then eventually after that, your IgM goes away. And so the thought is if you find someone who has IgM alone, the thought is they just got CMV. If you find someone who has IgG alone, it means they had CMV a while ago. And if they have both IgM and IgG, the thought is they're sort of in between those two. But the problem is the timeframes on these are very imprecise. Is that days? Is that weeks? Is that months? Right? Is it years? It's not well mapped out. So frequently someone gets, you check them in the first trimester, and they check them, they have no antibodies, fine. You have not gotten CMV in your life. You're at risk for getting it in theory, fine. Or if they have IgG alone, you're like, probably you had it a while ago. you're not immune because you can get it again, but you're fine. But if they have IgM and IgG, which frequently happens, you don't know, right? Did they get CMV a week ago, a month ago? Did they get it 3 years ago and now it's reactivating? Or is it or is it just your IgM lasted longer than most people do? And so it's very, very confusing. There is a secondary test called avidity testing, which helps to sort that out, but it's not perfect. And so I agree, there's always a lot of confusion when that happens. Yet there are doctors here who send them routinely, even though sort of the US sort of base organizations recommend against it. And then in certain countries like in Israel, they do recommend testing it routinely, and they do. And so it's not like, it's different in different places, but these same issues arise no matter what the policy is or what the practice is. There is still confusion if you test in the first trimester, and sometimes you can sort that out and often you can't.
So the argument for testing in the first trimester is there have been a few papers. It is not like the standard of care. There isn't enough data to say this is 100% the right thing to do. But there have been several papers that have shown a benefit of high-dose valacyclovir, Valtrex, to decrease fetal infection in patients with first trimester CMV. And so if you test someone and they're at risk, they're IgM positive, they're either IgG negative or IgG positive with low avidity, you can give them a high dose of valacyclovir. It's 8 grams a day.
That's a lot.
It's a lot. And it's enough where 2% of people who are taking that dose have reversible damage to their kidneys. And so it's not nothing. Like people who are taking this medication have to be monitored because it can be toxic. But they've shown that for people who take this and tolerate it, when you do an amnio later, their fetus is less likely to be affected. And, then they can stop it. And so, the argument for screening is that if you screen, you'll find something that you can treat and decrease the likelihood of something bad happening.
So what's the argument against screening then?
That we don't have enough information and that, we can do that in the first trimester, but we don't really have the data for the second and third trimester. And, with more, we may find out about more toxicities for Valtrex or, harm or something. There's not, you want more studies before you say all 4 million pregnant women in the US should be screened for this.
Right. And again, like you said, sometimes when you roll something out in a population, there are consequences that are unintended and may make it worse. So for example, like you said, if not everybody who does the screening really understands this very well, and the message that patients get is from the blood testing, your baby has CMV, they may choose to terminate the pregnancy or, whatever. Bad things can happen. They certainly can get a lot of anxiety. They can get a lot of harm to their well-being in that sense. And so it's not the simplest thing in the world. In current state, or 2025, or if this podcast gets dropped in early 2026, the current state amongst U.S. sort of OB and MFM societies is not to do this testing routinely, but it is done elsewhere in other countries, and some people in the U.S. do it anyways. But it's a really interesting question about which way is actually better, and maybe this will change with time. I don't know. I'm not sure how it's going to play out.
Yeah, I think it would be surprising to me if at some point it didn't become routine, but I think we need more data. We might need different medications. Because, this thing with renal failure is not nothing. And so you don't want, and this thing with people terminating pregnancies isn't nothing. And so you don't want people terminating pregnancies that would have been just fine. And you don't want people getting sick.
Yeah. Yeah. And it's, there was some hope, I remember years ago, for a different treatment of IVIG, intravenous immunoglobulin, but most of the big studies that were done looking at this were unfortunately not successful. So again, sometimes when there's early promise to a medication and then you do a larger follow-up study, you find, this didn't actually help at all. And so now we're just causing anxiety and all these treatments and all this stuff when it didn't actually help. So I agree. It would be nice to have a bigger study showing that an intervention is beneficial before you roll it out to everybody. I mean, 4 million people is a lot of people.
And then the other thing is that there are a lot of people working on CMV vaccines, but there is nothing currently available.
Ugh.
And so that could...
Why is that? You're a vaccine expert.
I have no idea. Apparently it's hard.
CMV is a hard one. Yeah, I mean, every virus sort of acts differently.
It's because there are different serotypes. So, we talked about how CMV can reactivate, but the other thing is that there are different strains of CMV. So you could get infected with one strain and not another strain. Like, that's another way you can get a non-primary CMV.
Yeah. No, I think one of the really important takeaways for our listeners is this is a complicated topic. And if you are thinking about blood testing or you had blood testing and the results are a certain way, make sure that the person who's discussing it with you is an expert. And that might be an MFM. It might be an OBGYN who knows about this. It might be an infectious disease doctor. Sort of depends, sort of where you are on this. But you have to make sure they have a sense, or you get a sense that they really understand what they're talking about here. Because if you get a blood test and someone says your baby has CMV, then probably they're overstating it, because we don't know that from a blood test. You really need to do more investigation to find that out. And that's because, I get consults all the time, baby has CMV, and then you figure out, well, no, like the mom might not even had CMV. Like there's so many steps that have to happen before we can make that diagnosis. And that's just an important point for this, I would say.
Yeah, the vast majority of people I see who are IgG positive, IgM positive in the first trimester, because that, it was just a test that was done routinely. They go on and have an amnio. The vast majority of them are negative. Like their baby is fine. Their baby is not infected with CMV.
It's good. It's reassuring.
But I think people are almost always very, very upset with that result.
With which result?
The result that their baby is at risk, that they might have had CMV in the first trimester.
Yeah, no, that's a very scary diagnosis to get. Good. Awesome. Shari, thank you for coming on to clear the air about CMV. I think this is really helpful and definitely more than I could just answer in like a 3-minute mailbag. I'm going to
mention one other thing.
Oh, good. Hit me. Hit us.
Because, I always have another thing. The data we have is like data. It's the same data about, the number of affected babies, I have the same numbers I had when I learned about this 30 years ago. But the pediatricians are doing amazing things. And they now have therapies for the newborns, which have decreased the likelihood of hearing loss, increased just the well-being of these babies. So I don't have updated numbers, but
right.
One of the things about a child being diagnosed with CMV is the pediatric landscape is, the obstetricians, we've done nothing in 30 years, but the pediatricians have really moved the field.
That's amazing. No, and that is important, because it would definitely give a lot of support to screening newborns in it routinely. If you could screen and do something and improve outcomes, that makes a tremendous amount of sense for screening. And that's sort of the paradigm.
Yeah. And they have the same problem, which is that they sometimes screen newborns. And like when they screen when they test babies that are symptomatic, I think they treat those babies. When they screen babies, it's harder to know what to do.
Right.
Because if a baby isn't symptomatic, some of them will get sick later, most of them won't. So then you're in the same situation. Do you want to give someone a medication that might be toxic or that might be inconvenient?
Right.
If everything is going to be okay.
Awesome. All right. Thank you for coming on the podcast. Great stuff. I appreciate it.
Okay.
Thank you for listening to the Healthful Woman Podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.